The whole body MRIs are not using any contrast material. Would they be any different, like in terms of harm or benefit if they were using contrast?
Yeah, good question. For patient populations that have an indication for whole body MRI, these cancer syndromes I mentioned to you before, they actually do use contrast material. And they use it because it allows you to detect and characterize things that are inside your body. In that case, the benefits of giving contrast outweigh the harms because that pretest probability of disease is so high. In an average or general risk population, these companies are electing not to use contrast material because it raises a lot of considerations for them as a company. And I don't want to speak on behalf of them, but it involves putting an IV catheter in. It involves being administered a contrast material that might have direct potential harm to you. It's rare for that to occur, but you're sort of trading off diagnostic accuracy for harms from the contrast.
You mentioned substantial harm, and you've seen some instances where this could lead to substantial harm. Because I'm sitting here as, say, an individual, and I'm thinking, well, I'm okay. I want to know what's there. I don't care what the potential harm is because I can make the decision if I want to do something invasive or not once I know that information is there. And if I think it's something that has a low risk, and my doctor tells me, yes, it's there, but it's low risk, I'm not going to then go do something about it. So I'm not worried about the harm. But then what if they find something that's really concerning, and then I'm willing to take that risk?
Right. Yeah, and that by the way, that logic is very intuitive. And if I was a layperson, I probably think the exact same way. Frankly, most healthcare providers think that way too. I know a lot of healthcare providers, they have that same logic. Here's the challenge, is that once you identify something, it's very hard to unsee that thing. And I'll give you a specific example. In patients who are over the age of 50, it's very common for you to have a thyroid nodule, which means your thyroid gland, which is in your neck, it's very common for you to have a nodule that grows in your thyroid gland. It's also very common for thyroid nodules to have small cancers in them. And this logic, well, if you're an older patient who's maybe over the age of 50, thyroid nodules are common, cancer in thyroid nodules is common, therefore we should go look for it. And in fact, this is exactly what was done in the United States and also more formally in South Korea. And what we saw when this happened, this well-intentioned effort to go find common cancer, you ended up seeing a dramatic increase in the incidence of thyroid cancer in both countries. In the US, it was by about 3 or 4x, and in South Korea, it was like by 9 to 11x. So a dramatic increase in the detection of cancer. And now we would think, that's great. We've identified early stage cancer, now we can treat it. And in both of those examples, that's exactly what happened. Is there was a well-intentioned, thoughtful effort. Well, we found the cancer, let's go treat it. And lots of people had their thyroid glands taken out, tens of thousands of patients. Lots of people had injury to the nerves in their neck, which caused problems. They lost these little glands called the hypoparathyroid glands that are in their neck and caused some hormonal complications. And many of these patients ended up on lifelong hormone supplementation. And only when you looked back in retrospect and said, let's see how we did. Let's see if we've helped the population. We detected all these thousands of additional cancers. How did we do? And what you saw is that the mortality from thyroid cancer did not change. So you end up with this tidal wave of detection of cancers. And everyone in the process thinks we're doing a good thing. The patient rationally thinks, I've detected an early cancer, and they've probably told all their friends and relatives, my life was saved. The doctor, well-intentioned, says we've detected a cancer early, we've saved this person's life. The payers, whether it's the government agency or a third-party payer, is saying, well, this is a reasonable thing to do, cancer should be treated. And so all the incentives and all the ideas are along the lines of we're doing a good thing, and only in retrospect you say, actually, we didn't help. Well, what we ended up doing actually was we caused a ton of unnecessary surgeries. And this was described in the New England Journal of Medicine articles, a series of them in the mid-2010s, and they described it as a, quote, epidemic of thyroid cancer screening. And the steps that were taken are, please stop. Please stop looking. Because once you look and you find, it's very hard to unwind that. We see this in a lot of other situations. In urology, for example, in small renal masses. In urology, for example, in low-risk prostate cancer. There's interest in pursuing things like active surveillance and sort of holding back and not doing it. But gosh, it's hard to do. And the average patient, when they're told, you may have a cancer, they're going to be pretty motivated to do something about that. And it comes back to what kind of cancer are we detecting? That's the crux of this. What kind of cancer? So if I have a very low pretest probability of aggressive disease, which is the average risk population, if I have a low pretest probability of disease, the kinds of cancers I'm overwhelmingly going to find are those that are indolent. So you can think of cancers in kind of, this is very crude and I apologize, but kind of three basic buckets. You've got your indolent cancers that are very unlikely to actually hurt you, but they are common and dwell in your body. You have some that are aggressive, which could go from development to metastatic disease really fast, like maybe in 6 months. And you have those which are kind of in the middle, where they have a stepwise progression of going from something indolent to something a little bit more sinister to something that's bad. If you think about those three kinds of cancers, the ones that you want to target for screening are the ones that are in the middle. They have this stepwise progression, and we see this in patients who have randomized trials, which recommend screening for things like colorectal cancer or prostate cancer or breast cancer, with certain kinds of cancers are being targeted in kind of an intermediate growth phase. The really aggressive cancers, the ones that kind of develop and go from zero to horrible real fast, they're not really well suited to screening because the odds that you randomly happen to image the person within maybe a 1 to 2 month window that you have before you can even do something, before the cat's out of the bag, it's just statistically unlikely. And the indolent cancers, if you end up detecting a lot of those, you end up driving a lot of treatments, a lot of biopsies and all the complications from surgeries and stuff that creates an illusion of benefit, but it's not actually helping. And in fact, this overdiagnosis problem is prevalent actually in prostate cancer, and it's one of the reasons why it's generated so much kind of feelings and complication around what's the right kind of prostate cancer screening to do. A recent study just came out a couple weeks ago, a very famous study, was conducted over a 20-year period, enrolled like 160,000 men, randomized to get PSA screening or not. And obviously in all these trials, there's a little bit of cross-contamination when people kind of choose to do something they're not supposed to do according to the trial. But they showed essentially by doing prostate cancer screening, it was confirmed to result in a 13% decrease in prostate cancer-related mortality, which is great. That's great. Amazing. That's amazing. And that says to me, we have randomized trial evidence saying this is the right thing to do for this patient population that's of a particular risk. And what they also found in that study, and what they also highlighted, is that patients who opted into screening had a 30% increased detection of cancer. And a lot of that cancer that was being detected was overdiagnosis. Some of it was appropriate, and you're getting some treatment benefit out of that survival benefit, which is that mortality benefit, which is exactly what you want. And some of what's being detected, a lot of what's being detected is overdiagnosis. And being smart with the screening strategy and trying to angle it in such a way that it targets the higher risk ones and minimizes the low risk ones, it's a combination of doing two things. One is being smart, like you said, and two is targeting the right population. The population has to have sufficient risk to justify doing it. Otherwise, the harm starts to outweigh the benefits, and you end up hurting patient populations. It's the same reason we don't do, for example, colonoscopy-based screening in 20-year-olds, because the harms outweigh the benefits.
Yeah. It is scary. So I mean, think about it. You find a nodule in your thyroid, you have a surgery, you injure your nerves in your neck, and you have chronic pain for the rest of your life for something that you didn't need.
Yes.
Right? That's the one that we can take from your example.
Yes.
But many of these things can happen. You can have very unfortunate circumstances, even from biopsies, even from endoscopies, these sort of tests that you do to diagnose an incidental finding on an MRI.
That's right. And I would say this is really common. And we end up dwelling a lot in anecdotes with this topic because we lack randomized trial data around it. So, one side says there was an anecdote where someone found a finding and my life was saved. And the other side, you give an anecdote of, yes, but here's all the terrible harms that could happen. I can give you one example of this. This is a very dramatic example, and I have permission to share this from the person involved. It actually was published in a New England Journal of Medicine evidence article. So essentially the person goes in because they have some shoulder pain, and their plan is to get their shoulder injected because their shoulder hurts. They get an MRI to evaluate the shoulder, and on the shoulder MRI, they found a lung nodule. They said, oh no, found a lung nodule. What are we going to do about that? So this is a classic example of an incidental finding. I mentioned before about 20 to 40% of all these advanced imaging studies have incidental findings. This is a classic example of one. So this individual is maybe in her late 40s, early 50s, has no particular risk of any lung disease. They're not a smoker, but nonetheless, they found a nodule. They said, well, we're not sure what it is. You have a low pretest probability of disease, but we have now generated uncertainty. We found something. So why don't we do a chest CT and figure out if there's other nodules? So they did. And they found actually lots of nodules all over the chest. There were a whole bunch of them. And the person was obviously terrified. And we didn't know what it was, and they thought, well, maybe it could be metastatic disease from some unknown cancer. Maybe it could be some bad infection. We're not sure what it is. Why don't we do a PET scan? We talked about that earlier. And so she's gotten the radiation from the CT. Now she's going to get the radiation from the PET CT. And it turns out that none of the lung nodules showed any significant uptake. But what they did find on the PET scan was they found something in the pelvis. And there was a little bit of uptake around they call it the adnexa, kind of like where the ovary is. And the PET scan said, the lung nodules are not showing any uptake, but maybe this problem is down in the ovary. Why don't we go take a look at that? So they ended up with a pelvis MRI. So kind of counting the studies here, we've got a CT scan, we have a PET scan, we have an MRI of the pelvis. MRI of the pelvis says the ovary is actually normal. We think maybe that was just some artifact from the ureter coming by, but there's some findings in the uterus, and there's a bunch of masses in the uterus. They're probably all fibroids, which are benign masses, but one of them looks a little funny. And what if those lung nodules are actually something funny from this uterine mass? And what was recommended was to remove the uterus. So this person now has surgery to take out the uterus for this lung nodules, which they were all benign masses. And I'm going to cut to the chase, but after this hysterectomy was done, the person developed a wound infection, an allergic reaction to some of the antibiotics that they were taking. They've had, I think, 3 colonoscopies because they still don't know what the heck the lung nodules are. And they were being offered a biopsy for the lung nodules, and the person said, stop. Please stop. I'm being tortured. And this is what happens, is you get on, they call this, there's a famous description of this called a cascade of care. And it's well described by primary care doctors, where one thing begets another thing, and you end up in this vortex, and you can't get yourself out again. And this is the risk, unfortunately, of doing sensitive imaging tests in low-risk patient populations, because you're going to overwhelmingly detect these indolent or unimportant findings. And by the way, the conclusion of the story is these lung nodules have no meaning in her life, and she's completely fine.
And was her uterine mass something?
They were benign. They were fibroids. Benign. So it was all just a rabbit chase. It was all pointless. But once you get on the train, you can't get off the train. The person's living their life. They're a totally functional, happy person, but for about a year of their life, they were terrified they were going to die of metastatic disease, and they had an unnecessary surgery and complications from surgery, and that is the problem when we do this. And if we have time, I'd like to just describe one thing. When we have screening tests are affected by common biases. You can think about whole body MRI as a screen, essentially, of your body. And some of these biases of screening, which are very well known, are length bias, lead time bias, and overdiagnosis bias. So lead time bias, what that basically means is, let's say that you have cancer that's detected and you live for 3 more years. Your apparent survival was 3 years with that cancer. Now let's say we detected that cancer actually 2 years earlier by some imaging test. Well, now I've got 2 years from me knowing about it, and then the symptoms develop and I got 3. So 2 plus 3 is 5. In that patient, even if I do nothing, even if I don't treat the disease, even if I've given them no therapy, their apparent survival is longer. And this is a common bias of screening. A more insidious bias, which I think is very common with whole body MRI and other things like it, is something called length bias. And it goes like this. Let's imagine you have 2 types of bad things. One is really indolent and unlikely to hurt you over a 20-year time frame. And one is something that's very aggressive and is going to go from just starting to going to kill you within 1 year. And let's say they're equally prevalent in the population. And I randomly sample the population. Just randomly choose, I'm going to image you on this year. The thing that I'm going to overwhelmingly detect are the things that are going to be in your body for 20 years, as opposed to things that can be in your body for 6 months or 12 months, because I'm randomly sampling the population. This length bias helps explain why a lot of the things we find when we're over-detecting end up being those indolent or low-risk disease, because we have flipped or inverted the ratio of important disease.
And if you like this clip with Dr. Matthew Davenport, make sure to check out the full episode right here.